I want to include one flow chart, but didn't have time to do that. Start with the basic BRCA test. See what kind of results you get. If you get a wild type results, then go for a promoter methylation, right? Some companies have already started doing that. So this will be like a low cost approach, more affordable approach for a country like India or Africa and other Asian countries. So once you are not satisfied with our traditional BRCA1 and 2 test, then you can go for a HRD gene mutations test. So you have to escalate, right? The second level of testing. Then the third level of testing, you can go for the HRD test. So that will be my approach. Of course, when it comes to treatment, we stick to the guidelines. So that will be my approach. So start with the low cost test first and see how the data comes, then slowly escalate, add one test on top of that. So it doesn't matter what cancer, like this is so BRCA panel, HRD gene mutations panel, and HRD test. All these three tests, it's for tumor agnostic now. We have to understand it. Not today, it's 4 cancers. Tomorrow will include lung cancer. Tomorrow will include melanoma. Melanoma may not come. Skin cancer may not come, but any other organ will come. So all the reproductive organs, all the cancer which are hormonally driven, right? So because if you see prostate and ovaries and also breast, they're all hormonally driven cancers. They have similar biological pathways behind the scenes, right, in the cells. So this HRR pathway is important for all these hormone. Even pancreas, you have both endocrine, ectocrine parts in the pancreas. I'm not sure if it will come in the neuroendocrine. BRCA pathway will not be applicable for a GIST or a NET, because that's a totally different ball game. That's PDGFRA and PA3 kinase and other AKT mutations. That's not in the BRCA pathway, but definitely the endocrine part, and also the maybe kidney cancer, we don't know, renal cell carcinoma, maybe thyroid and parathyroid. So all the hormonal cancers, wherever there's a hormones are triggering the cancer growth, could fall under this. So this HRR test can very well become a tumor agnostic test. This is going to be more and more significant in the coming months when the newer trials are getting published. San Antonio press conference will come now very soon. ASH will come, but that's in lymphoma, leukemia. There is some evidence, but there's different pathways in lymphomas and leukemias, not just the HRR pathway. There are other pathways involved, like the non-homologous end joining pathways are involved. We suspect that's going to play a bigger role. And promoter methylation is an untapped market. So we are banking on this particular biomarker because nobody is offering promoter methylation in India right now. I think Medgenome is actually working on it. They might be offering it very soon. So if you want to test it, if you have some patients, you want to check if the patient has BRCA promoter methylation, we can do it as a research project. So right now, everything is clinical trials. We don't charge anything. No, it's we can send a phlebotomist to pick up the samples and stuff. So that was the main agenda here. The first was to create the awareness for the clinicians, both the medical students and doctors and the practicing physicians, whoever is watching the webinar. So for them to create the awareness to understand the difference between these 3 levels of testing, just the BRCA alone, then you have the HRR gene mutations panel and the HRD status. So HRD status is very, very challenging. So not everybody can offer that, and it's more expensive. So I will reserve that as a last step, unless you want to go straight to HRD first. I forget BRCA1, forget these things. Give me HRD. Give me genomic stability score first. That is also fine with us. We can do that also. So that's the whole objective of this talk. And the second is being a startup. We have been funded by the Pfizer Innovation Grant. We've been funded by Biotech Ignition Grant in the beginning. So we are funded by all government grants and private and also angel investors. So we are currently doing a 3,000 patient study for these 4 cancers: breast, ovarian, pancreatic, and prostate. We are working with Apollo hospitals, we're working with AAG hospitals, and a bunch of public-private trust-based hospitals like Kidwai Memorial, Adyar Cancer Institute, and a whole bunch of other hospitals, right? But nowadays, getting patient samples is very challenging because we have to take it through a proper ICMR ethics committee approvals and stuff. But clinicians, you are free to send sample wherever you want. So with the disclaimers, this is not a FDA approved test. This is, as of now, it's a lab developed test. It's a LDT under the quality guidelines of NABL, and NABL is like CLIA. In the US, they do like CAP and CLIA. So CAP is for pathology and CLIA is for the clinical laboratory. So we don't have CLIA, we have NABL and we have CAP. We're going very soon, we're getting CAP very soon. We already done some validations already. So this is a validated test, but not clinically validated. This is a validated test with the known positive controls, synthetic controls. And this is a long read technology. So it's a lot more affordable compared to what Myriad and Foundation are doing. They are charging around 3 lakh rupees or something like that. So we want to bring it down all the way down 1/10 the cost in that 30 to 40K, that $500 budget. A $3,000 to $5,000 test, we want to bring it down to the $500 budget. It can be even go lower once we scale up on volume and everything. It will be like very, very affordable solution for a country like India. That's the whole idea. The other point I want to make before I wrap up is like, according to ICMR statistics, we don't have the latest 2023 statistics. I think this is 2018 or 2019. So we have 5.5 lakh new cancer patients diagnosed every year, new cases, roughly around 150,000, 1.5 lakhs new breast or ovarian cancer cases. So in that, let's say 100,000 cases, right? 1 lakh patients, breast cancer patients, new breast cancer patients, 1 lakh patients, just an arbitrary number, right? It may not be perfect, but it's definitely more than that. I'm just giving a very, very conservative figure. So 1 lakh patients, newly diagnosed patients all across India. And how many of them are actually getting a DNA test done? The answer is less than 1%. So 99% of women are not being offered. They don't even know that such a test exists, right? They're not even being offered the test. That is the bigger challenge here. I can launch innovative test tomorrow, but if it is not part of the guideline, if it is not part of the regular clinical workflow, what is the point, right? In the US and other countries, the insurance companies make sure that they order the test. They will not reimburse because it is FDA approved, it's part of the guideline, and the insurance companies force it, right? In India, it's not like that. Many countries where the system doesn't work, it all depends on the individual clinician's his own interest, right? If they are interested, they will do it. If they're not interested, say, I don't need it. With or without a test, this is the treatment I'm going to start. So why bother doing the test, right? So the question here is, roughly about 25% in that 1 lakh patients, 25% will be eligible for PARP. I'm not saying PARP is for everybody. 75% will not be eligible, right? 3/4 will not be eligible. 25,000 patients are eligible for PARP inhibitors, but they're still going with traditional surgery and chemotherapy with very poor outcomes, right? So that is the impact that we want to create. So we want to offer the test to everybody, and we want to create awareness. From 1%, we'll first reach 10%, then 20, 30, like that. Slowly, the coverage should improve to such an extent, every cancer patient has to get a DNA test done, right? It should be, that's the ultimate goal. So we are not a profit-centric company, we are a patient-centric company and a data-centric company. So data is the key. So we are more interested in collecting the data, right? That's why we are offering the test for free as part of the clinical research. So that's with that, I'll conclude that. Thank you.
Thank you, sir. Thank you so much for the wonderful and informative presentation. So now I would request all the attendees to post their question in the chat box for question and answer session. While we wait for that, sir, I would just ask you, what would be the 3 major takeaways from this topic?
Yes. So the first is BRCA1 and 2 testing has now grown bigger and bigger. So now we have a whole two new levels. The first level is the HRD gene panel, gene mutations panel. That minimum you need that RAD51C, you need, apart from BRCA1 and 2, you need the PALB2, you need the BRIP1, CHEK1, but the RAD51C complex is very important. There have been some studies where they didn't do the complete panel. They only need BRCA1 to PALB2 and RAD51. This is what we are thinking. We can have a low cost, like a 3,000 rupee test or even less, like the COVID RT-PCR test. Just 4 genes. like a quick screening test, right? So we can easily tell whether this patient has HRD status, yes or no, as an indirect biomarker, like a screening test. These are the minimum 4 genes, but if you want to be on the safe side, that 15 genes that I showed you, that's the 15 gene panel. Anything more than 15 is overkill, but that's a minimum number of genes that you need to test. So right now, to my knowledge, only MedGenome and 4BaseCare are the 2 companies offering this test in India. Then the HRD test is a whole different level altogether, where you're looking at the genome-wide, very, very large chunks of DNA, right? Like a karyotype kind of thing on a sequencing NGS data. It's very expensive test. It's minimum like $1,000 and above. So I'm assuming it's 75 to 80,000 is what these other guys are charging. I don't have the actual data. It could be more than that also. So that's why I said, why waste money on the HRD test when you have the low cost options? Nowadays, BRCA test done in 5,000 to 6,000, under 10,000 rupees budget, you can get it done. If somebody is asking more than 10K, that's a waste. Don't go to them. It should be in the 99, best case scenario, it should be in the $99 price point, because it's only 2 genes. You're only sequencing 2 genes using amplicons, and it's very low coverage. And the HRR gene panel is around $1,000. HRD could be $2,000 or $3,000. So that's the range I'm seeing in the market, right? So it's newly launched, and a lot of doctors don't have complete confidence in the test, and they don't have also some doctors have not actually tried the PARP inhibitors, so they don't have confidence in PARP inhibitors also. That's a different problem altogether. I'm only talking about companion diagnostics. So first you need to have some good experience with PARP inhibitors, and then only you have to think about this. But this is part of the guidelines now for these 4 cancers. Also, many of these tests are already gone through so many clinical trials. So it's a proven concept. It's not a novelty. It's a proven concept. It's going to really matter for those 25 to 30% of your patients. Let's say breast cancer, ovarian cancer, literally 1/4 of them will benefit. They will benefit from PARP inhibitors. So this is a challenge with targeted therapy. So a lot of doctors, they try targeted therapies for just 1 or 2 patients. It doesn't work. The patient this is still progressing. Then they lose faith in the treatment and say, oh, all these targeted therapies are all, just eyewash. They lose faith. So, sir, you have to treat at least 100 patients. You will see at least 25 to 30 of them benefiting. Of course, that 70% may not benefit, right? So it's a numbers game, So just testing in 1 or 2 patients and then giving anecdotal evidence. I tried for this patient, didn't work. Yeah, it didn't work for that patient. Maybe it works for somebody else, right? So that is the awareness that we want to create. It has to become part of the clinical workflow, because it's already there in the US and other countries. In India, it's not there. It's not the HRR and HRD test. It's yet to be adoption. It's a challenge in adoption. That's the key takeaway. So now we have to figure out how to improve adoption, and how to create this awareness, and not just for the medical community, also for the patients. The patient should come and ask, sir, is chemotherapy is my only option? Is there any other treatment, right? Patients should start asking these questions, right? Because patients don't even know there's something called the PARP inhibitors, there's something called immunotherapies. They don't even know, right? Unless we tell them, they don't know. That's the challenge.
So, sir, we have one question. How does HRD status affect the choice of treatment for these cancers?
Yes. So if the HRD status comes as positive, then the patients are eligible for the PARP inhibitors. If it comes as negative, then you just go with the other pathways. So when you have a decision tree in the NCCN chart, do the test. Is the result yes, go this direction? Result is no, go in that direction. you go with the traditional chemotherapy or hormone therapy, whatever the standard of care, right? So this is a companion diagnostics to decide which patients are eligible candidates for PARP inhibitor therapy. That is the whole objective of the test.
So we have one more question. What are the implications of HRD evaluation for personalized medicine and targeted therapy?
Yes. So right now it's only for these 4 cancers, because these are the only clinical trials that happened, right? Just wait for a couple of more months and maybe a year or 2. I'm sure this is going to become a tumor agnostic biomarker. HRD status is going to be a very big, just like NTRK gene fusions and TMB, tumor mutational burden, and MSI, microsatellite instability. So my good friend Dr. Vivek Subbiah, he's the main person for all these red gene fusion studies, and he's a very young chap. He's younger than me. We are both the same medical college from Kiel Park. So he's like 2 or 3 years junior to me. But he has become so popular nowadays. He's in MD Anderson. Now he's in Sarah Connor Research Institute. He was invited to the ESMO conference in Paris, and he was given the opportunity to be the plenary speaker. That kind of opportunity is given only for like 60-year-old, 70-year-old senior oncologists who are about to retire. That lifetime achievement award kind of person. So this is the first time a very young doctor was given that opportunity to give the keynote for ESMO last year in Paris, because he was pioneering this red gene fusion, and he was the principal investigator for 3 drugs, and he's continuously pushing the boundaries. So me and Dr. Vivek Subbiah, 25 years ago, when we were in MD Anderson, we were discussing maybe these biomarkers are not supposed to be just for one cancer, because this is a universal mechanism. Maybe they are in multiple cancers. So we didn't have the terminology tumor agnostic. That terminology was given by some pharma company, I think BMS, Bristol Myers, or AstraZeneca. Somebody coined that terminology. But we already suspected many of these biomarkers are universal mechanisms. It's not just for one cancer. It should be applicable for multiple cancers. We already suspected 25 years ago. Today, it's becoming a reality. So I was the PhD guy doing my postdoc in MD Anderson, and he was doing his fellowship, hematology oncology fellowship. But he was a lot of interest in solid tumors also. So he had like 3 to 6 months clinical rotations, research rotations, and he was, as part of the fellowship, he's supposed to submit one research article. So I motivated him into personalized medicine. Today we have all this terminology, personalized medicine, targeted therapies, and all these terminologies. Those days we did not have, we did not even have that nomenclature. For example, take CAR T cells. We say chimeric antigen receptor T cells. That's the latest name for the immunotherapies for lymphomas and leukemias. Those days we used to call it as adoptive T cell therapy. So we didn't even have the name called CAR T cells, right? So that's a story. So this is what happens in science and medicine. Some visionaries, they have this long-term vision, right? And they are like ahead of time, like what Elon Musk says. Everybody lives in the present, and the entrepreneurs are the ones who live in the future. So I've already seen the future, right? I'm trying to deploy now, but everybody is in the present. They don't understand what the future holds. So it's a tough time for me to communicate. That's the story. So adoption, that's a huge challenge in adoption. It's the same with HPV vaccine. Today, Serum Institute is launching the 4-valency. I was talking to some of my colleagues in the obstetrics and gynecology. I said, what is your opinion? I said, until now, we didn't have anything. At least now something is better than nothing. But the real HPV vaccine is supposed to have at least 6 or 9 valency, 9 different strains, pathogenic strains of HPV. HPV is again a very favorite interest because cervical cancer, it's not just an infectious disease, also in cancer, right? And HPV comes and goes, right? Just because somebody is HPV positive doesn't mean they will develop cancer. Then what is really going on? So this is basically virus-induced DNA damage. The virus entering the cell, causing a DNA damage. But if the person has a perfectly normal BRCA proteins, perfectly normal PALB2 and RAD51, so they don't have any HRD mutations, the DNA damage is fixed. But the women who have problems in this group of proteins, the DNA damage cannot be fixed, and they develop cervical cancer. So cervical cancer could be a next candidate, but I don't think anybody will be interested in taking olaparib or rucaparib for cervical, because traditionally we think it's only radiation, right? We think chemotherapy and radiation and maybe surgery. So cervical cancer is a very high analytically scenario, but lung cancer already some studies are going on, especially for both squamous cell and non-squamous, SCLC and NSCLC. The HRR pathway is very important, and we are seeing a lot of overlap. We used to think squamous and non-squamous are 2 different ends of the spectrum. They are not. They're actually, maybe we'll have a talk on that. squamous cell, later recent studies, a very large genomic study, they shown there's no big difference between squamous and non-squamous. It's just how it materializes. There's a phenotypic variations, but at the genotype, they're exactly the same. That means every treatment that works for non-squamous cell will also work for squamous. That's a good news. So now, until now, these people didn't have any treatments. So now, but there's so many drugs, right? You name it, they have it. There's so many drugs for NSCLC. So now the good news is everything that works for NSCLC can also be tried for squamous cell lung carcinoma. So there has been more studies, more clinical trials to explore this. So that's the future. The future is going to be tumor agnostic biomarkers and tumor agnostic therapies. That is the future what we hold. So then where is the personalized? Personalized is again gone. So now we understand where the pharma companies, what they're thinking. They're losing money, right? There was a time when they make one drug and it's applicable for everybody, one size fits all approach. Then there was this huge push for personalized medicine and targeted therapies. But now this doesn't work for 100% of them. It's only work for 5% to 20, maximum 25, 30%, right? I'm losing 70% of the market. So how do they compensate? The cost of the drug went up, right? So take the gene therapies, cell-based therapies. Recently, Sarepta got one therapy for muscular dystrophy. It's a very challenging disease. India, we have so many dystrophy patients. The gene therapy costs $3 million, right? How many patients have that kind of money? Almost 30 crores, right? $3 million. Who can afford a 30 crore treatment in India? Right? Why is these medicines are so expensive? Even the MAPs, even a $1,000 monoclonal antibody, 1.5 lakhs, pembrolizumab. Nobody can afford it because it's not just a one injection. You need it for an entire year. You're looking at a minimum of 10 to 12 lakhs treatment cost per year, right? And you have to give it at least for 6 months to see if it's working or not, right? So that's the challenge. So the cost of these starter therapies and immunotherapies are very high because they want to compensate for the 70% loss in market. That's why the pharma companies are now liking the idea. They're endorsing tumor agnostic therapies and tumor agnostic biomarkers because now they can go and give it to everybody. It's going back to the roots, right? One size fits all approach. So then where is personalized? Personalized is gone. So that's the story here.